Hey everyone, it's Andrew Penn, one of the co-founders of Open Nurses. I want to welcome you to this month's Psychedelic Chat. I've been away for the last few months, so it's nice to be back here. And my pleasure to introduce tonight's guest, who's Nathan Levitt. Nathan is a family nurse practitioner, is also a Robert Wood Johnson Foundation Health Policy Research Scholar and Jonas Nursing Scholar. He is the director of the LGBTQ and Gender Justice Learning at Yale University School of Nursing and is currently at the Hunter-Bellevue School of Nursing in a nursing PhD program with a focus on health equity. I know one of the questions we often have is about graduate training, so we can definitely talk about that tonight. Nathan also works at Marpa Minds, which is an outpatient mental health clinic specializing in treating depression by offering safe, effective, and affordable ketamine treatments. Nathan has been teaching LGBTQ healthcare to nursing and medical schools around the country for over 20 years. His clinical practice included working as a clinician at Folx Health, which is a digital healthcare service providing customized medical plans for the LGBT community. And he's worked as a nurse practitioner in the gender affirming surgery program at NYU Langone Health, where he provided education, preoperative, and postoperative care for transgender patients seeking gender affirmation surgery, as well as providing hormone therapy. Nathan was the first New York State Family Nurse Practitioner Fellowship program and became the Director of Transgender Care at Community Health Network, CHN. He's worked as a transgender health consultant in New York State and the New York City Department of Health, and he's worked for 8 years at Callen-Lorde Community Health Center, providing care for LGBT patients, building transgender health programs, and creating and facilitating curriculum on transgender health. Nathan trains and consults for community health centers, health professional schools, hospitals, and community-based organizations, and has been published widely on transgender health. So it is my pleasure to welcome Nathan onto the screen here. Nathan, welcome. Hey there. Nice to see you.
Thank you so much. Nice to see you too. I'm happy to be here.
Yeah. And as people kind of roll into the room here, I want to encourage you to go ahead and put where you're watching from, and as we go through our conversation, we'll save some time at the end for any questions that people have that they can go ahead and put in the chat, and we'll save some time at the end to pull those up and discuss those. So, Nathan, I always start these these sort of conversations the same way, and I just love to know, nursing is such an interesting field because we all get to different places, different ways, different paths. What was yours? How'd you get here?
It's such a great question, and it's so true about nursing. I actually teach nursing now at Yale School of Nursing, so I'm seeing all the different paths that people take to get to this field. But it's actually a second career for me. So I started more in kind of social justice organizing. It all feels connected to me, but I really started in working with communities in LGBT communities and communities that experience different discrimination and access to healthcare issues. And so I was doing more advocacy work, kind of on the ground with communities. And I started to feel like that the barriers to healthcare, especially for LGBTQ individuals, but really, so many people that experience racism, transphobia, all of the different forms of oppression, were experiencing these barriers to care. And myself as a transgender person, I was experiencing a lot of barriers to care. And while I was doing all the training and educating people and getting people together, I thought, what if I just get in the healthcare field and I help kind of create that access and more compassionate fields of care for these populations? I don't know. I thought it was going to be easy, and it really was not. I thought, just jump into nursing. And so I was working actually at Callen-Lorde at the time, which is an LGBTQ health center, and I was doing training and education for nurses and other healthcare providers. And I realized, I think I can really help in a different way by entering the field. And so that's when I started nursing school. I worked as a registered nurse for about 5 years at a mostly medical surgical unit. I did some oncology or cancer care, and I kept that foot planted in community health. And I did a lot of community health work. And through that process, I realized I want to keep continuing on, even though I thought I would not go back to school. And then I became a family nurse practitioner after working as an RN for a few years, because I really wanted to still open up that, accessible and safe environment for populations, and especially in the field of, prescribing and being a primary care provider. So that's how I ended up in nursing school, and then kind of continued on in the ways you explained already in my bio. But I really worked at these different community health clinics to create safe places for the community to go. And now I can't imagine not being a nurse. I feel like it's just such a huge part of who I am. I've been a nurse practitioner now family nurse practitioner for 5 or 6 years. So in all, I've been a nurse for about 10 years. But before that, I was already in the healthcare world, just kind of figuring other ways to connect people.
Yeah. I'm understanding that the nursing part and the community part, particularly the LGBT focus, where do psychedelics come into that?
Well, it's interesting. I mean, I think about the paths that I would have never expected to get here. I really didn't know a lot about psychedelics, especially in nursing school. And I think, that's something I'm also working to change. And I feel really lucky to be a part of this university psychedelic education program where I get to see Andrew as well and training nurses and social workers around psychedelic care. But I didn't get any of that in nursing school at all. I didn't hear much about it until I started working with specifically transgender communities that were experiencing different forms of trauma and really high degrees of PTSD, a lot of depression, a lot of anxiety, as would be expected, because of the environments that we're in and especially the ways in which this community has been treated in that way. And I remember that I had talked to a nurse who said that they were having these breakthroughs with a transgender patient of theirs who had started different ketamine-assisted therapy at the time. And then I had heard about different psychedelics that were working for mental health issues as well. And I just saw the transformative changes that were happening for the community that nothing else was working for, right? All the antidepressants, the therapy, different forms of medication were not really making much of a change. And then entering this world of psychedelics and getting that kind of compassionate and, ethical care made these huge changes for people. So I realized this is something I want to try to get involved in as best as I can. And so I involved myself in a lot of research. I talked to a lot of different communities. I noticed that there was a lot of fear, which made sense, when there wasn't enough information. I certainly didn't get it as a nurse in nursing school. Now there is more, but certainly not enough. And then there's fear from communities too, just feeling like, is this something that's going to be informed? Is it going to be sensitive? Is it going to be aware of the different things that I go through? And I got the opportunity to work actually through a friend of mine who was a patient at the place I work at now, who said to me, this is life-changing. I'm getting this, specifically they started as Spravato. So it's the ketamine intranasal. And they started to notice these changes that, this person in my life had been on antidepressants for 20, 30 years and not much change at all in their level of depression, but a few sessions of Spravato and specifically in a really beautiful healing space was making a big change. And this friend said to me, I think you should work there. I think you should take, all the things that you're passionate about and you should bring it here. And I didn't know if it was going to be possible for me. And it was really amazing because the people at Marpa Minds, where I work, they're very much interested in the kind of energy you bring to something. And sort of, even though I hadn't come from a lot of experience working within the, ketamine-assisted therapy or ketamine field, they're like, we can teach you about the psychedelics, but what you need is that connection to people and that sort of healing modality energy. And so that's how I got, involved in that, and then involved in this university psychedelic education program. And now feeling like I just want to bring this to all the different communities that I work with.
I want to come back to the question about LGBT folks and psychedelic care and ketamine, but before I lose track of it, for people that are watching this, maybe not be that are not familiar with the UPEP program, could you speak to that a little bit?
Sure. So it's a really extraordinary program, in my opinion, that really looks at what I was saying around how these schools, these helping professions, nurses and social workers, really being in the field to help so many communities that are suffering from different mental health, experiences or mental health issues, to connect themselves to these healing modalities. And what this group of people realizes that the nurses and social workers are really the ones that have that direct contact with patients that need this care, yet they're not getting that education within the school. And so really coming together and saying, what if we started a program that really teaches social work faculty, nursing faculty around how do we bring this curriculum, this content to the future nurses and social workers. And so it's an extraordinary program that I feel really lucky to be a part of, that I think will just keep growing and changing and really reach so many people so that we are educating future providers to know how to take care. Because right now there's just there is evidence out there, there is research out there, but we're not seeing it come into the schools as much as we would like to. And so this program is really working on that.
So it's really teaching the teachers how to teach this content.
Right. Exactly.
Yeah. Which is different than like, I think a lot of, especially in the last 5-10 years, there's been a lot of these schools popping up to train people to be clinicians in this space. And what you're really talking about is I was just thinking as you were talking, it's kind of like when I went through nursing school 20 years ago, harm reduction was a really radical concept.
Right.
Oh my gosh, you're going to, there's all the reasons why people resist that, but now it's just part of standard curriculum to talk about that, and even if I'm not trained as a harm reduction therapist, like at least I'm familiar with the idea of harm reduction and some of the basic concepts. And it sounds like what you're talking about is UPEP is trying to get nursing and social work faculty to be at that level of familiarity so they can at least teach that as part of their offerings in those schools.
Right. And also sharing with each other, because people are doing this across the world, but really bringing people together to say, well, what content are you bringing in? And how can we learn from, the up-to-date research that's happening right now? And how can we connect to all of the different practices that are happening, that we can make sure that we're teaching it in these creative ways and these really affirming ways that they can bring into their own practice.
Yeah. What's been your experience at the Yale School of Nursing in terms of receptivity to this kind of content in your curriculum, and where do you teach it? Like, where does it get integrated into the curriculum?
Yeah, I think there's certainly resistance everywhere, because I think it's a lot of fear. It's a lot of, and especially in nursing, I feel like nursing works so hard to be taken seriously. And really, we just have I feel like we have really amazing radical roots of social justice and helping people. And we often lose sight of that. Yeah. And so I do feel like the resistance is more about not having enough information. And again, not having it so we don't see it on the, there's a lot of teach to the test, right? And this is not going to be on the boards. It's not going to be on the NCLEX. Right. So I think there's a real fear of bringing in that information. But when presented with all the evidence that's out there, and even more than the evidence, just the transformative change that is happening for people, especially around mental health and especially around like self-discovery, I do think there's more openness. And, there was a support letter that was written for me to be a part of the University Psychedelic Education Program from my program. And that is something that we're really excited about. 2 other faculty with me as well. And, it's a process, I think, like anything, and starting to bring in that education. I teach in a gender and sexuality health justice concentration, which I wish was mandatory for everyone, but it's an elective at this time. And it is really an amazing opportunity to reach populations that really need this care and teach people how to take care of, marginalized populations. And so I bring some of that into the concentration already, because we talk a lot about trauma-informed care. It's such a big part of reaching different communities that are affected by these, systems of oppression. And so when we think about trauma-informed care, we think about what modalities are out there that are healing. And so sometimes that's how I'll bring some of that in, and I'll just help my students kind of see what's working right now.
Yeah. Well, and as you're kind of pivoting from going the teacher hat back to the clinician hat, we know from epidemiologic work that LGBT folks suffer from higher rates of mental health complaints, and particularly trans folks. There's a much higher burden of depression, anxiety, suicidality, whatnot. So there's no shortage of need clearly in that population. Do you think that there's anything that is unique to psychedelics with that population and with the problems that they face that offers them additional benefit beyond what we normally do, therapy and medications? Like, is there something about psychedelics that is different?
I do believe so. And I feel like there have been some research that's been done specifically on transgender populations and psychedelics. Not enough. I want there to be a lot more. But what I intuitively know just from my own experience and then working with communities is that because of the trauma we experience and because of the sort of like multiple microaggressions and just existing as a transgender person, especially right now in this political landscape that we're in, to have these constant attacks on who we are as people and the inability to be authentically ourselves can take such a toll on who we are and can build so many walls and so much distrust, especially in the medical system, especially because it is so binary and
Yeah.
your body parts and how you identify and who has access to care, as we see now with attacks on trans care for trans youth. So what I think psychedelics can do and have done is build that trust back and allow people to have some self-compassion that feels somewhat impossible sometimes, especially for trans communities, to be able to connect with yourself past all the mistrust and the anger and the discrimination, and to actually get in touch with who we are and access parts of ourselves that feel hard to access outside of it. And I think it can be transformative, especially if it's done in a way that's understanding of what these different communities face, right? Like especially people that experience multiple forms of oppression. So, if we're thinking about Black transgender women or other communities that experience, combining intersections of oppression, it can be so hard to reach those populations with what we have, with therapy, with medications. But when you're actually using something that's going to sort of like build these new pathways and create this more compassion, and a kind of change that honestly seems really almost impossible with other avenues, with where we're at now, So with an understanding of what these medicines can do and the ways in which we can get more in touch with ourselves and feel connection, I feel it can be really transformative.
Yeah. And of course, some of those demographics that you're describing aren't well represented in healthcare settings. So, if you're a Black trans woman, you're probably not going to walk into a clinic and see people that look like you.
Right.
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 And so then, to your good point about the distrust that that comes from experiences with the healthcare system, if this is being delivered as a mental health care offering, how do we kind of mitigate that sort of barrier? Because I could see a lot of people saying, I'm not going in some clinic for that. I've had bad experiences there.
Yeah, and that's such a good point. I think so much of this work, I think about this a lot as someone who does community health, and the example of, the first community health job I had, where I learned about mobile that would go to communities, health vans, when people didn't feel comfortable coming into the clinic.
Yeah.
And, if you think about New York City, there's a lot of homeless LGBT youth that are on the piers, and they're not going to come into a healthcare clinic. They're not going to feel comfortable. They may not have insurance. They may experience discrimination on the way in. And the van sort of meeting people where they're at and saying, building trust with the community. And I think that's a big part of it. And why I feel like folks in the community will come to a place where they see themselves represented, like you're saying, where people can say, I know the healthcare system has been awful to you, and you've experienced all this trauma within it. And here are the ways we're trying to work on it. We're going to have more people that, understand your experiences. We're going to explain how these medicines can help, work past some of the issues that you're dealing with, and really building trust with a community that has so much, lack of trust there, and also has, never really had the opportunity to have someone say, I want you to be able to live your authentic life, right? I want you to be able to have joy, and that's something we don't often bring into the healthcare world.
Yeah, no, for sure. Yeah, I mean, it feels like we're at this really curious time with psychedelics where, if you'd asked me 5 years ago, this sort of the push was to bring these into healthcare systems to get them FDA approved. We called them all medicines.
Right.
We adopted a lot of the kind of language around healthcare, and what sort of seems to have like passed us on the well, you're supposed to pass on the left, right? It feels like it's kind of passed us on the right is decriminalization.
Right.
And I think if you'd asked me 5 years ago, I'd say, oh, these are probably going to get approved, but they'll be at special medical clinics. And now the longer I think about it, the more it feels like there's a good chance that, there may be medical uses down the road, FDA approved things, but the vast majority of people receiving these will probably not be in those settings.
Right.
They'd be in community settings. And I know our colleague Caroline Dorson has done some sort of ethnography around this, around ayahuasca circles in New York and such. I mean, do you see that being a more palatable model for delivering this to LGBT folks because it doesn't involve the medical system?
Yeah, the thing that I really love a lot about Marpa Minds, where I'm doing the ketamine therapy, is that they've thought about ways to make it not feel like a medical setting. And I think it makes such a big difference. It feels like a spa setting. It feels like you're doing something special for yourself.
Yeah.
They have integration specialists who can sit with you and talk about your intentions and how you want to bring in the new learnings that you've had, and really focus on your comfort. And so when I think about the first kind of psychedelic groups I've heard of that were connected to LGBT communities, they were separate from medical institutes. They weren't connected to hospitals or health centers. They were retreats. They were places where you knew you were going to be with community. You weren't going to see that sort of hospital setting that brings up can be triggering for a lot of trans communities. And that it was beautiful, that we could have nice things. But I think that, one of the challenges is always financial, and there's pros and cons, of bringing it into medical settings. Like I think about the place that I'm working on, it is FDA approved and they're getting insurance coverage, which is huge, even with, Medicaid and Medicare, which usually was not something that would cover this. And so it's access for people that don't have the financial means to go on a retreat, and it does bring that access to them. But I do worry about the ways in which, it can be brought into this medical center and like commercialized in a way that loses its focus on that healing, modality of meeting people where they're at.
Right. And it just becomes another treatment to give somebody.
Right. Exactly.
But your point about, access through things like Medicaid and Medicare is really valuable because, as much as people like to sort of bag on FDA, the FDA process or pharmaceutical companies or whatever, that is how most people pay for their treatment. Right. And most of us don't have $3,000 lying around to go to some, weekend long retreat.
Right. Exactly.
Especially people in marginalized communities really don't have that kind of resource. And as you were just talking about the sort of taking the sort of I think I'm old enough to remember like ACT UP, and the early days of the AIDS crisis, and really that healthcare and political activism were intertwined, and as part of LGBT, just freedom to live, and have access to potentially life extending or life saving treatments. So I'm hearing, in what you're describing, that kind of that scrappy nursing, like go to where the people are.
Right.
Find out what people need and don't assume you know what people need. Right. Which, I love that kind of radical side of nursing, right? It's like, well, we're just going to reinvent this thing because what we have now isn't working.
Exactly. Right. Those are our roots, I feel like,
They really are. I mean, in psych nursing, I think about like Dorothea Dix, it's like these asylums are terrible. They need to be completely revised. Like she was a social justice activist before, on top of being a nurse, right? And that's a deep vein that runs in our history. Are there other things that you think nursing brings, perhaps in actually like the delivery of care, kind of zooming in more towards like the patient level, or zooming out if we haven't covered it already, that is a different kind of perspective?
Yeah, absolutely. I mean, I think there's a reason why I feel so passionate about nursing. And I do feel like there's something that we bring, that we look at, or we should look at the holistic nature of people and thinking about the many different factors that are involved in chronic health issues or whatever the case may be. We think a lot about our housing. We think a lot about community, family, all of the different factors that go into a patient being in front of us. And, I learned this from working night shifts in a hospital that which is quite an experience, but you really bond with your other nurses, is that we take care of each other and we take care of our patients. And we listen in a way that I don't always see from, other healthcare providers, that listening part of, there's something else I'm hearing. This isn't just about, you didn't take your medications, or this isn't just about whatever it might be. Like there are other factors here. And I think that part of the way that we think about patients and think about their holistic care is a way that we bring in psych care. Like I do teach now, and I teach all different specialties.
Okay.
And I always say to the psych folks, like, we should have everything you have in your specialty should be in every specialty, because we all need it. I'm a family nurse practitioner, and I had a few courses. Now I have a lot more because I've taken it upon myself. But I think we think about mental health in different ways. And that does allow, I do think in a lot of ways, psychedelics and nursing is such a clear connection for me, because it's that holistic care and it's thinking outside the box. It's like, well, this isn't working. So what else could be going on here? What are other ways that we can connect people to who they are and themselves, and how can we make sure they have a transformative experience that when they leave this hospital or this health center, it's going to stick, right? Like they're going to keep making these changes and be on this healing path.
Yeah. I always say all nurses are psych nurses.
Absolutely.
Regardless of what it says on your badge, like if you're dealing with people that are sick and having transformative life experiences, you're a psych nurse.
Right. Yeah, absolutely. I mean, I remember being on this unit, they'd always call in psych for everything, in the middle of the night. And we would just, as nurses, we'd come together and say, what are the ways we can think about their mental health? And we don't always want to call in the psychiatrist. It's not always the best match. No. Sometimes it's just sitting there with them and talking to them and getting on their level and understanding what's coming up for them and how we can be there for them. And there's something about that night shift. It was a long time ago, but I really remember it well because we didn't have the resources and support that they have during the day. So we were just kind of on our own, and we figured it out, and we connected with people, because even if I don't understand all the medications or I don't know all the pathophysiology, I can sit and connect with someone. And that's what I feel like I'm doing a lot in this ketamine clinic, is sitting with people and just saying, we're here for your healing, and whatever you need for that process, like we're going to be. And for a lot of people, what I noticed is they had never been taken care of. Nobody had ever said, what do you need? I mean, something as simple as, do you want this weighted blanket put on you? It was transformative for one of my patients who said, I didn't even think I could ask for something that would make me more comfortable.
Wow.
And it's such a simple thing, but it is something that is going to help them in their process and sort of get them out of their head and towards discovering more about themselves.
Yeah, it kind of reminds me of like the research around psychotherapy. And those of us who do therapy think that, the thing that our patients will remember is some brilliant interpretation we made. Right. And the reality is, like, they remember, like, when I handed you a tissue box when you were, and said, it's okay, go through as many as you want, that's the kind of thing people remember often, is just, it's the little things, but they're really impactful.
Absolutely. I think about this. I do a lot of trainings for healthcare centers around being more inclusive to trans communities. And yes, there's a lot of training on clinical care of trans communities, but often I'll give this story of what a provider did for me once, which was I had a really hard time coming to this patient appointment. I'd experienced at that time a lot of transphobia just on the subway, just getting there.
Yeah.
I didn't say any of that, but I sat down, and instead of going right into it, which, as healthcare providers, we don't have a lot of time with our patients, she just said, I know it must have taken a lot for you to get here today. And I know there was probably a lot of issues along the way. And I'm here to talk about it if you want to, and anything I can do to make you feel more comfortable before any of the, like, what brings you in today.
Yeah.
And I think that just be understanding that people are going through so many different things before they are even in front of you.
Yeah. Wow. I just kind of got the chills hearing you say that. It's like acknowledging that the appointment started well before they walked in your office.
Absolutely. Yeah.
And that they probably weren't sure if they were going to do this several times over before they actually walked in that office.
Yeah.
I mean, thinking about nursing in this space, and you've already thrown a few of these ideas out there. We hear at Open Nurses, I hear a lot from people. I get the emails when people sign up on our website, and so I hear a lot of, like, I'm trying to figure out what my role will be in this, and it's interesting because it feels sort of undefined still. I mean, the whole field, it feels very much a work in progress. Like, how much person-to-person care is actually going to be included. How much of this is going to be therapy based versus like just kind of letting the drugs do their thing. And it feels like the lack of sort of clear definition for nurses has them either feeling despairing or feeling like they have to kind of emulate other professions that are have put a bigger flag down in this, and it's interesting because I don't know why psychotherapy felt like it got to put the flag first, right? Like, is this really, the domain of psychotherapy? There's a lot of things that don't seem to square very well. It's like with psychotherapy, right? And I'm hearing more, especially from some of the sort of pharmaceutical driven studies, like the MindMed study just published this last week in JAMA Psychiatry, and they had a very light touch model, so like it was really somebody in the room, but we're not doing a lot of therapy. We're just making sure you're safe. We're making sure you're comfortable, but we're not going deep, right?
Right.
They had pretty good results, and it's like I'm hearing from those folks increasingly that like nursing seems really well aligned with this, so it may be in the future we actually look like visionaries.
Yeah, right.
We could take credit for it when
absolutely.
I don't know, it's kind of a long shot 10 years ago, but I think, yes, that was exactly my vision.
Right.
But it was our vision. Like, this is what we imagined it would be a good fit. Are there ways that you can see nurses being involved in this that maybe they might not be thinking about? Because you clearly have expanded nursing in a really broad way. And I'm wondering, sort of, for people that are at home going like, I want to work in this space, but I'm not sure what to do. I'm a nurse.
Yeah.
What do you think?
Yeah, I mean, I think there's so many opportunities. And, I learned a lot from these integration specialists that I work with at this ketamine clinic to think about sitters, to think about the way people can help guide people through these experiences, the way that nurses can come in with both like a clinical mindset and also that therapy mindset, or that, making sure someone feels comfortable and builds trust with them. And all of that relates to what we see, research in psychedelics around set and setting. I think of set and setting a lot for many different reasons, definitely related to psychedelics, but also related to nurses, because I think that's a lot of what we do. I was just today I do skills assessment with the students, and I was just laughing at how much work we put into, we knock on the door and come in. It's such a small thing, but I've been in medical schools where they don't talk about how they walk into the room. It's a different model. And I think about set and setting in that way. Like when we come in, we are already thinking about how we enter a space and how we make that patient feel comfortable. And that is so core to psychedelic work and to therapy work too, that when you enter a space, you're thinking about how to make that person feel comfortable. So roles for nurses are anywhere from kind of sitting with someone as they're going through this experience. Sure. Obviously we take vital signs, we think through that, connecting them with, we have a lot of questions around medications, the medications they're taking and psychedelics, other kinds of chronic health issues, like navigating. I worked as a primary care provider for a while, so I know what it's like to be that sort of core when you refer people out, but you're still the core connecting all of their care. And so there's a way we do that as nurses too. Oh, you're going to this referral site, or you have this health issue, or you're having this problem at home. How can I be a resource to connect you to the care that you need? I think there's so many different opportunities for nurses in this kind of care in a lot of different settings.
Yeah.
And I think it's kind of amazing to think about all the roles that nurses could play.
Yeah. And I like what you're saying about the way we knock on the door. Cause I mean, there's an element of consent.
Right.
It's like, can I enter this space that is yours?
Yeah.
Rather than just assuming that I have the right to kind of barge in there because I'm in, some deciding capacity. Right.
And I think that many of us think about treatment differently. I think that word comes up a lot with psychedelics, or like, treatment resistant depression, which is sort of like not, I don't think it's the most affirming phrase to use to put it lightly. But I think that we do think about what works and what doesn't work for different reasons other than it's just the medication. Like we're thinking about all the other factors. And that, with psychedelics, I feel like there's so many different factors to when they open people up or when they don't, or when they have lasting effects or when they don't. And then it's a way of thinking about, quote, treatment in a different way.
Yeah. Yeah. You mentioned earlier around LGBT folks and particularly trans folks in the psychedelic space. And, I'm wondering what your thoughts are about, obviously we're not that great at being more representative in our research studies. When you look, psychedelic studies in particular tend to be, pretty white, pretty highly educated, pretty affluent, and a lot of them still have binary gender demographic gathering, right? And so
Right.
that's not that alone sends a message that the way you're seeing the world. Are there things that we should be thinking about as psychedelic nurses to be more inclusive to LGBT folks, but particularly trans folks?
Yeah. It's a great question. I think especially now it's quite timely. There's just so much going on for the trans community right now, especially in the US, but beyond as well, with these sort of attacks that are happening for our rights and our access to healthcare. An awareness of that goes a long way. I do think, even researchers that are bringing in communities and thinking about how trans people are experiencing psychedelics or experiencing trauma or experiencing just living in this time right now is quite unique and important to bring into the research, because we know from research that if it's focused on a particular population but not inclusive, it's not going to work for everyone, right? And it's not bringing in these other factors like how is our race affected, or our trans status or our sexual orientation by these different healthcare visits. So when we bring in the communities most directly affected, everything works better. We start to understand that these communities that are experiencing all of this, if we can bring them into the research and we can see how do we maybe change our language to be more inclusive. I'll give an example. Like often people ask if you want like a woman or a man practitioner, or if make certain assumptions about people's body parts or their safety in a space, and all of that communicates to the community, this is not going to be the most inclusive place for me, or a place where I can feel like I can be myself, my complete self. Asking people's pronouns, making sure that, things are inclusive around language. But when trans people are not involved in the research or in the conversation or in the publications or in the, experiences, then we don't get to learn about, what could be most helpful and most inclusive to those populations. And specifically around trauma, because I think a lot about PTSD and complex PTSD in these populations. And when it isn't an understanding of how people experience it in their bodies and their identities, we're missing a really big part of trauma and understanding trauma. And I think psychedelics, there's so much research on the amazing effects of psychedelics on trauma and depression and other issues like that. But when we don't have a complete understanding of how different communities experience that trauma, it's not going to be inclusive and it's not going to be successful for those
right. Yeah. And this is a pretty basic question, but I've met well-intended clinicians who want to do well, but they're kind of afraid of getting it wrong.
Yeah.
And so they'll sort of stumble because they're like, I don't want to say the wrong thing,
right,
and upset this person, right? As if they're sort of like made of, just made of sugar or something.
Yeah,
if you say the wrong thing. But any advice for somebody like that who's well-intended but just is like, I don't know if I say the wrong thing, what's going to happen?
Right. I appreciate that, because I feel like there's a part of it that is caring and compassionate and trying to do the right thing. So I feel like we'll start with the appreciation. And I think the second part of that is there's a beauty in honesty. And it sounds like a really simple thing, but I've had practitioners say to me, I really want to be the best, I want to provide the best care for you. I don't have a lot of training. We all know that this isn't included as much in nursing schools and other schools as it should. I'm coming in and doing those trainings for people. But the honesty of saying, I haven't received a lot of training on this. I'm scared to make a mistake. can you let me know if I use language that is offensive or that makes you feel uncomfortable, even though it sounds like something you may not want to say because it sort of admits that you don't know everything. I would much rather someone say that. And then when they do say something, because everyone will mess up, it happens, then I know there's an opening for me I feel more comfortable to say, thank you for earlier saying that I could bring this up, that word you used or whatever. And then making sure that your response is one full of gratitude. Thank you for educating me on that. And also makes a change. So when I say that, the reaction I'd love to have is, thank you for letting me know. I'm going to make sure I put this in the chart, or I educate my other providers, or I make sure that your next visit, like there's an apology, there's a gratitude, and then this is how we're going to try to work on it next time. And that to me shows there's a real commitment to change, because we will all mess up. We didn't get experience or training in this. We'll mess up around so many things, but that openness to being corrected and to being educated around it, and to show that you really do care and you do want to make that experience good for the person.
Right. Yeah. I remember having a new primary care provider once. He came in and put the papers down, put his hands in his lap, sat across from me and said, I've read your chart, but I would love for you to tell me, what do I need to know to take good care of you?
Yeah.
And I was like, whoa.
Yeah.
I was blown away. I was like, that is the best first line I've ever heard.
That's a really good one.
I'm stealing that, as a provider myself, like, because when we're patients, we're all secret shoppers.
Oh, absolutely.
Right.
You do a lot of secret shopping.
Yeah. You're like, how do they do it here?
Yeah. And I do that a lot also to see there's a lot of assumptions that are made, especially around trans people. Like if I walk into a healthcare appointment, people assume that I was, born male and that I have certain body parts. And especially within healthcare, it's a really harmful assumption with anywhere from like what tests you're going to do, what body parts you're asking questions about, what medications work with, all of those assumptions can be really dangerous. So just sort of approaching everyone like you don't know how they identify, you don't know what their body looks like, you don't know their trauma history, you don't know what they've experienced before they walk in the room, which I do feel like is a lot of the core of nursing, is that not to say that it doesn't happen, but that we try not to make assumptions about people that walk into our office.
Yeah. Well, and I think what you're describing is like basic humility too.
Yeah.
Like I may get this wrong, and I hope we can work through that.
Yeah.
If I do, because I want to do better. It's like the old, what is it, Maya Angelou, when you know better, do better.
Exactly. And to show that you're doing work too. I think there's a part of this where I felt like in a lot of healthcare visits, I was spending 20 of my 20 minutes I have with my healthcare provider educating them on trans health. There's a line between asking for education and also educating yourself too. So I can, you can say, what, thank you for this information. I'm going to do more research on this, and I'm going to make sure that I'm not just having you, take over this visit and educating me.
Right. No, that I think sometimes contributes to the sort of tentativeness that, I think more thoughtful clinicians sometimes have. Like they're aware of that. There's a labor to educating other people, and you might not be filling up for that work.
Right. Exactly.
Or you didn't ask for this work.
Right.
Certainly not being compensated for it. So,
exactly.
Yeah. I do want to encourage a handful of people that are watching live, if that you do have questions for Nathan and you want to put those into the chat, this would be a good time to do that as we get sort of towards the tail end of our conversation here. One of the things we always ask folks on these interviews too is have you encountered any kind of backlash or resistance or skepticism? It's interesting. We've been doing these talks now for like 4 years. And even just in the 4 years we've been doing it, like 4 years in psychedelic land is like, it's like dog years,
Yeah, totally.
It's like really like 28 years. But
right.
It just feels like this is a less relevant question, but I also want to be aware that I'm in San Francisco, you're on the East Coast, like there's a lot of space in between those two things where, you might get a raised eyebrow or two if you said you're interested in psychedelics in Des Moines.
Right.
Not to pick on Iowa, but have you run into any of that?
I sort of feel it in, depending on who I'm talking to, I can feel that there's skepticism. I wouldn't say I've experienced backlash per se, but I've also been aware of people doubting the care or this field, or feeling like there's not enough research, or feeling like maybe they've heard one bad story that is completely unrelated to the actual care we're provided, and they'll use that. And so often I try to lead with the research that's out there, the evidence-based work that's there, and then patient stories, patient transformative stories, which I think go a long way. I think there's a lot of fear about licenses. I noticed that, like, people will say that to me, "Oh, are you scared you're going to get your license taken away?" And I just think there's a lot of fear that's not based on correct information, and not based on the evidence we have and the research we have, and without an understanding, because it's often not included in school. So I tend to follow it with, again, that evidence, the patient stories. I connect people with resources. There's so much more, as you know, now than there ever was before. So we can point them to different sites to say, this is something you can look into and get some more information. I've had the place that I'm working at now, we work with their healthcare team. And so I've had actually a therapist reach out, the patient's therapist, and saying that, she didn't feel comfortable with the patient going for this care because she didn't know enough about it, and she thought it might be detrimental. And I spent a long time, maybe too much time, educating her on this. And now she wants to go into ketamine-assisted therapy. Now she's like, this is also now is noticing the change that this patient made in, I think, 5 visits with the Spravato was more transformative change around depression than this patient had in 20 years.
Wow.
So sometimes it's about really connecting them to these lived experiences that make a big difference.
Yeah. Now that what also highlights, when we were talking about sort of the maybe non-direct clinical care roles that nurses have, is that we're educators, whether or not you're in a formal teaching role like you and I are, or if we're staff nurses, we're always teaching.
Yeah.
Right? And we're trusted. We're trusted sources of information. I always think back to, like, when the COVID vaccines came out, how many of us had friends and family, they're like, should I do this or should I wait? Like, they came to us to ask that question. And so, kind of to your anecdote, that the psychedelics is also a place where we can educate people. And it may not be in the clinics. It may be at a barbecue.
Yeah. Absolutely. Right. Yeah. Sometimes it's just conversations. And, it's interesting. That is true. But be at a party or about somewhere where someone will just stay, have questions about it, or maybe their family member went through it. And there's just so much information out there that's coming out more and more, and these basically transformative experiences for people. And I do think the coming together of nursing, of the LGBT work that I do, helps impact the ways in which I talk to patients too. Like, I do a lot of their psych evals before they come in for, to make sure that they meet the criteria and that they be suitable for the treatment. And I bring in a lot of the, talking about sexual orientation, gender identity, talking about what kinds of traumas people have experienced. And I've had interesting responses from people in their psych evals saying, I haven't had other therapists or psychiatrists even ask me about my identity before. And that doesn't make me want to start care with them, and especially start any kind of care like this. So it does help to kind of build down bring down those walls. We don't know how someone identifies just by looking at them. So really having those conversations can make a really big difference.
Yeah. My students would tell you, I say this all the time, is that, your patients are assessing you more than you're assessing them. Right. And especially if you're in a marginalized group, that's even more true, right? Because you're assessing this clinician of, like, can I share this about myself with you?
Right.
And part of that assessment is based on what they ask.
Yeah.
Because you kind of broadcast, like, what you're interested in knowing by what you ask, right? So you asking those questions about identity and experiences of gender and sexual orientation, it tells the patient you want to know.
Right. Yeah. And by the time they come to me, usually they have been in the mental health world and been in and out of visits with psychiatrists and therapists for so many years.
Yeah.
They almost approach it like, oh, I'm going to get all the same questions I always get, and it's not going to go anywhere. And so really starting off in a different way of, like, what does wellness look like to you? Or what are some barriers you faced in the healthcare system? Already kind of break down some of those walls.
Right. There's such an opportunity to do something just even slightly different, to really surprise our patients, because you're right there. We've all gotten kind of inured to this like mediocre treatment,
Right.
So when we get slightly better than mediocre, it's like, whoa, wow, that was really
exactly.
good.
I know the bar is really low.
The bar is super low.
Yeah.
Like, I used to do this crazy thing of like, I don't know, calling other clinicians to tell them that I met with with a shared patient, and they'd be like, whoa, no med providers ever called me before. I'm like, that's terrible. But
I got so much gratitude from a psychiatrist for calling him to update him on the patient.
Yeah,
we're part of a team. We want to, let each other know.
We're both working for the same patient. Like,
Right.
we're accountable to that person. Like, we better communicate with each other. There's a few questions trickling in. Wendy's in the control room here. She'll offer something up here. All right. Do you feel that nurses require an advanced degree? You have an advanced degree. Do you think that's essential for doing psychedelic work?
I don't, I really don't feel that way at all. I feel like it helps a lot with, at least, there's certain practical things like prescribing that's helpful for. But the core of this work, like I've talked about before, is not at all related to degrees. It really is related to that compassionate care that we really learn in nursing. But the degree itself, is not really a part of what makes this magical and transformative,
Yeah, agreed. What else we got, Wendy? Oh, here's an interesting question. So everyone's talking about psychedelics now.
Right.
Any perils there, you see?
Yeah, like I was saying earlier around like the commercialization of it, I've rarely seen that gone to a positive place. And so I worry sometimes. I even worry with the way things are approved if they don't. I'm not saying that everyone needs to have therapy involved, but I think that there's a therapeutic aspect of it that it's really important. A therapeutic aspect that's based on an understanding of psychedelics and of trauma and all of that. I get worried about the mainstreaming of it, where clinics can just pop up that are not necessarily connected to this sort of, way of healing and way of connecting to therapy and way of looking at the holistic care and, those sorts of things that I want to be part of all of the care. I want us to be thinking about all the different factors that go into mental health. So I worry that the mainstreaming could lose some of that. But I'm hoping that, the research that's out there and the stories that we hear that are so connected to the ways that we want to guide people can maybe be integrated in.
We had an interesting panel about this in Denver at Psychedelic Science this year about, this question of what's the sort of dose of therapy that needs to be delivered. And, that a reasonable point was made that there's a lot of ketamine infusion clinics that have almost no therapy. As part of it. And people get better. Do they get better for as long, or in what ways do they get better, and how are you measuring better, are all reasonable kind of pushbacks. But, it's interesting. I sort of imagine a future where like there's a whole range of options, right? Because I think about the veterans that I treated, a lot of them would be like, I don't want to talk about this stuff.
Right.
Kind of taciturn guys that like just want to get better, and telling them like, well, you got to do all this talking before you get this med.
Right.
Like, that would actually reduce their access to it, because like, well, then forget it. So for somebody like that, maybe they can just kind of dip their toes in with a very light on therapy model, and then people that really want to take the deep dive can do that too.
But what that comes back to is what we were talking about, is meeting communities where they're at, because some communities are going to need a little bit more and some aren't, but still at least having those conversations and having an understanding is going to impact their healing.
It's such a good point, because I think a lot of times we make these assumptions about what people want. And like half the time it's like you ask people in that community, like, is this what you want? They're like, no.
Yeah, exactly.
I don't know who came up with that term, but like, I don't want to be called that.
Yeah, exactly.
I was just having this conversation with somebody recently about like the term Latinx. They're like, I don't know where that came. They were like of that descent, and they're like, I don't know where this came from, and I don't really want to be called that. So like it was just kind of foisted on me. So just ask people. Just ask people, right?
Exactly.
Like, it's not rocket science.
Right.
Hey, Caroline's got a question for us here. Great. Caroline's been hanging out in the background, apparently. Thanks for great chat. Basic question: do you include SOGI? I'm not sure what that stands for.
Yes, sexual orientation and gender identity questions.
Oh, okay.
Absolutely. What a good question. I think I think it should be included in everything, but it's also about how training people to know how to ask those questions. So I include it in everything that I do. Everything from every, in every healthcare context I work in. But I also explain, we want to make sure that everyone can be their full selves here. We're calling people the right names. We're understanding their gender. I'm going to ask you some questions about your sexual orientation and gender identity. I also make sure that, people know they don't have to answer them. People know why we're asking them, especially right now. There's a lot of fear about anything being documented in any chart about someone's, especially their trans status right now. So I speak to that from the beginning. I'll say, I don't need to put any of this in your chart. I can make sure the whole healthcare team knows you use these pronouns, you identify this way, you want to use this name, maybe just in the clinic, but that's not your legal name. We have ways of making sure you're going to be treated with respect in a way that feels comfortable for you. But if we don't ask those questions, that's when people feel really uncomfortable, because I know right away when people don't ask me those questions, it may not be a place where I'm going to feel comfortable.
Yeah. So you communicate a lot by what you don't do.
Right, exactly.
Yeah. All right. How many Spravato sessions do patients typically have at your clinic, and how quickly do you taper them?
So we start out, and I think most places do, in the first 4 weeks, they have 2 Spravato sessions a week. And so the first 4 weeks are really front loading a lot of that care. And then we check in, we have an evaluation along the way, and we talk about maintenance, and maintenance would be once a week. And people do once a week for as long as they need it. And we continue to reevaluate. A lot of people do once a week for a few months and then feel like, I'm seeing the changes I want to see. This depression feels lifted. I don't need to come back. And some people feel like, I want to continue maintenance for a while, maybe once every 3 weeks. But that first 4 weeks is pretty set. And then we go to that once a week, but always kind of checking in for what works best for people.
Yeah, that's really interesting, because it does feel like, while there's now data for long-term Spravato maintenance, I feel like we've got like the depression scores, there's good maintenance data for that, but like the phenomenology of that, like what is it like to have that built into your schedule once a month or something, like where are you going on those journeys,
right.
Despite what Johnson & Johnson wanted to kind of put out in the world at the beginning, it's like, ketamine does have psychedelic effects.
Yeah, right.
Whatever you want to call them, they
Yes.
are psychedelic. So,
Right.
I mean, do you see people using that kind of opportunity for personal exploration as well as keeping their depression symptoms to a minimum?
Yeah, I mean, the things I've seen, I don't think I could have even prepared for how people, especially some of the patients who come in that barely even want to speak, that they just are feeling so depressed, they're not even leaving their homes. They want a lift of depression. And then in addition to feeling this lift of depression or a decrease in suicidal ideations, they're finding this self-transformation process. They're connecting with family they haven't talked to. They're learning patterns about themselves. They often say things like they feel like they're outside of themselves looking in and identifying things that they never saw before or never understood about themselves before. And it's just really remarkable to see that change, and also the way in which it can happen so quickly for people if they're open to it and if they're really integrating it into their lives.
It really is an opportunity that feels kind of underappreciated in some settings.
Yeah.
That like, the biological drug will probably lower your depression scores,
Right.
but don't overlook this quote unquote side effect, right?
Right.
Totally. Could be really, really helpful. Yeah. So we always kind of end these interviews with the same question. It's kind of a fun way to bookend it. And that is, if you could go back and give your younger self a piece of advice. My younger self, I'd tell him to close the blinds behind me so I don't look like I'm getting a halo here. But what would that piece of advice to your younger self be, Nathan?
It's a great question. I really think it actually connects back to your first question around how I got here, because I think this message that I would tell to my younger self is, you really don't know where you're going to end up. I never thought I was going to be in nursing. I certainly never thought I was going to be in psychedelic care. So really just having that openness to follow paths that I would have never imagined I would be on, and the ways in which they've brought me to real transformative places, which actually also connects to psychedelic care. I feel like it's just an openness to a transformation that I couldn't have imagined when I was younger.
Oh, that's beautiful. Yeah. If you're at the beginning of your journey, it's really hard to know where you're going to end up. I mean,
Right.
If you'd asked me in college, was I going to be a nurse? I would not have seen this. And I certainly didn't imagine the way my nursing career was going to go. So
right.
And that's okay. That's half the fun, right?
Exactly.
Yeah. Oh, this has been really, really nice to have you on here. I'm glad.
Great.
I know we've been talking about doing this forever, so I'm glad we finally made it.
So happy.
Finally made the time and made it happen. I really
Thank
appreciate
you so much
joining
for
us.
doing this.
Yeah, and a lot of people watch this on the replay since we have these.
Great.
A lot of people are still getting home from work on this end of the coast, so they catch these on the replay. But been really good to have you here. If people want to get in touch with you, is there an easy way to do that?
Yeah, so probably the easiest way is through my email, with it's just my first name, nathan.levitt@yale.edu.
Okay, 2 T's.
Yes, thank you.
Levitt with 2 T's. Yes, excellent. All right, Nathan. Well, thank you so much. I know it's late on your end of the country, and really appreciate it.
It's nice to see the sunlight on your end.
I know, right? Well, it just appeared from under the fog here.
Right.
So, yeah, this is our time of year where we actually get some nice weather from time to time. So
I love that.
Excellent. Well, good to see you. Have a good night.
You too.
Thanks, everyone. Thanks for watching.
Bye.